Hello, my name is Ibrahim Kim. I'm the Executive Director of the Council of Korean Americans. We're so thrilled that you could join us for this webinar today. This week, we're focusing on how Korean American physicians and medical experts are on the front lines in this fight against the COVID-19 pandemic. We've invited two doctors for our conversation today. First is a surgeon from Mount Sinai Hospital in New York City. As many of you know, New York is at the epicenter of this current pandemic crisis. Second is an emergency room doctor from Texas who currently supervises and oversees a dozen different emergency rooms across the state. Together, the three of us have a very engaging and interactive conversation related to a number of different topics related to the COVID-19 pandemic. One, we look at how the current crisis may be having a strain and putting pressure on our current public health and medical infrastructure in this country. Second, we look at the unusual nature of the COVID-19 virus and how there are strange symptoms that are often associated with patients that are suffering from the coronavirus. Third, we look at the societal and long-term impact that the COVID-19 pandemic may have on our communities, especially as we talk about social distancing and flattening the curve, and what does that mean? And then finally, we look at what kind of information is available to the Korean American community, especially as individuals seek to protect their loved ones, their families, and friends. Special thanks to the Korean American Medical Association for not only this information for these resources, but also our current doctors are all members of the Korean American Medical Association. In fact, they're both regional presidents of New York and Texas, respectively. With that, we hope you enjoyed today's webinar. We hope you find it very informative and help you navigate the current crisis with this COVID-19 pandemic. Thank you very much.
Welcome everyone to the Council of Korean Americans Executive Webinar. My name is Ibrahim Kim. I'm the Executive Director at the Council. We are so honored to have two distinguished guests, two physicians who are on the front lines of the COVID-19 war. First of all, they represent an important organization called the Korean American Medical Association. It's a national organization that represents physicians of Korean heritage, and their vision is to support Korean American physicians to excel in all aspects of medicine and promote mentorship and education and share medical knowledge and skills for the betterment of the Korean American medical community. Today we're honored to have Dr. Sanghyun Alex Kim, who is currently the regional president of the Korean American Medical Association in New York metropolitan area. He is currently the surgeon and chief of the Division of Colorectal Surgery at Mount Sinai Beth Israel in New York City. And then secondly, we have Dr. Christopher Kwon, who is currently the regional president for the Korean American Medical Association of Texas. And he is an emergency medicine physician and the founding partner and board member of Physicians Premier Emergency Rooms. And he's calling in from Corpus Christi, Texas. So welcome to both of you.
Thanks for having us.
So Chris, let's start off with you. Could you give us a broad sense of some of the important facts we know about COVID-19. Obviously in the media, there's a lot of information. Some of it's good information, some it's not so good information. But we'd love to hear from you in terms of what are the important facts about this disease.
Yeah, absolutely. Even as physicians, I've been living and breathing this for the past 2.5, 3 months. And there's somewhat of an information overload. So I can't even imagine as a layperson, how do you kind of wade through all of that? But let me just kind of point out maybe some facts and some data that's somewhat robust. I know that there's new data coming out literally every day, every hour. But I think the data that I might point out has been fairly robust over the period of this pandemic. So we can kind of start there. About 80% of the people that actually get this disease will be perfectly fine. Part of that 80%, however, there's a debate as to what percent. Some people talk about 20%, as high as 50%. I think they're conflating some issues there. But a small portion of that 80% are completely asymptomatic, or they have such mild disease, the person actually that has the disease does not know that they actually have it. So they become, if de facto, asymptomatic carriers of the disease. They're shedding enough viral load that they're actually transmitting the disease, but they just don't know that they're doing that. Now, obviously, as people have heard, what we're not concerned about is the 80% of the people that will do fine, but it's the 15 to 20% of the people that will not do fine. And most of them will be sick enough to be hospitalized. About 4 to 5%, some of the data coming out right now, about 4 to 5% of that 15 to 20% will be admitted to the ICU, and they will need ventilator support. It is also known that this actually, if you want to compare it to other, I guess, infectious disease, a flu, influenza is actually something that you can kind of compare it to. Many epidemiologists, many clinicians believe that COVID-19 actually spreads much faster, and they're much more transmissible than the influenza virus. Now, the influenza virus, the epidemiologist uses the term called R0 value, or what they call a reproductive value. And the last 10 years or so, the reproductive value, or the R0 value for influenza, has been about 1.4. Basically what that means is that if you have the flu, on average, you'll be passing it to about 1.4 other people. Now, the estimated R0 value, the estimated reproductive value for coronavirus is actually 2 to 3. And so if you can think about that, it's much more transmissible, it's more infectious than the influenza virus. But if you really think about that, that R0 value, or that reproductive value, is not a static constant, right? So if you are completely sequestered from anybody else, if you are self-quarantined and you actually don't see anybody, there's no way you can pass it to anybody else, right? And so that R0 value, or that reproductive value, actually is not static, and it will change depending on the environment, depending on what the government does, depending on your healthcare system, etc. Also, the influenza mortality rate over the last 10 years is estimated to be 0.1% over the last 10 years or so. And last flu season, 2018, 2019 flu season, about 35 million people got the flu. I think the US, if my memory serves me, is about 350 million people in the US. So roughly about 10% of the population in the US suffered from the flu last flu season. I don't know the data on, obviously, 2019, 2020 season, but that's the data that the CDC actually reports on. And so if you see the mortality rate of influenza being 0.1%, about 35,000 people have died because of the influenza virus in the last flu season. Now, what the CDC reports, and actually it's very difficult to ascertain the exact number because a lot of people have comorbidities. Did they really die of the flu as a result of that? But the number that they actually reported in the CDC from last flu season is 34,200 people that have died from the flu last season. Mm-hmm. Now, as far as the mortality rate of COVID-19, it's all over the place, and we can kind of talk about why that's so. Right now, I think the latest number that I'm seeing right now in the US is 2.9 to 3%. I think Spain is at around 10%. Italy is at 12%. I think South Korea, they were hovering mortality rate of 0.6 for a long time, and they bumped up to close to 2%. Germany also used to be around 0.6%, and they're jumping up to about 1.7, 1.8% as well. World Health Organization pegs the mortality rate of COVID-19 as 3.4%. I think when it's all said and done, mortality rate is actually a simple math, right? It's the number of people that have died because of the disease divided by the total number of people that actually get it. But the numerator as well as the denominator could be very difficult to ascertain in the midst of a pandemic. And if I were to take a professional guess at this, when it's all said and done, let's say 2 years from now, in retrospect, we look back and see what the true mortality of COVID-19 is, I would venture to guess it's going to be hovering around between 1 to 2%. Now, having said that, if you compare that to influenza virus, it's actually order of magnitude higher than the influenza virus, right? So the mortality rate for influenza is 0.1%. Even in the conservative estimate of COVID-19 being 1% mortality, that's 10 times the mortality rate of influenza. And if it happens to be about 2%, maybe even higher, basically COVID-19 will kill about 20 times the rate of influenza. So that's the most daunting part of all of this, is the mortality rate is order of magnitude higher than the influenza, right? So if you do some math, there's 350 million people in this country. If nothing is done, if there's no forced social distancing, if no intervention is performed, then you can pretty much assume that because the R0 value is just as high, if not higher than influenza, about 35 million people can potentially get the coronavirus. If it's 10 times the mortality rate in influenza, you would expect that 350,000 people will die. If it's 20 times, it's close to 700,000. And that's why last week or so, I believe there was some epidemiologic modeling out of WashU that estimated potential death if all these social distancing measures are implemented even up until August. They projected the death rate to be about 100,000 people dying in the United States, about 200,000 people dying in the United States. In fact, actually, they readjusted that number today, I believe, or yesterday. The WashU really influential, highly respected modeling came out, and they readjusted that model to, they think that about 82,000 people might die because of the coronavirus now, if the social distancing interventions are fully adhered to up until August or so.
Let's bring in Alex here. I mean, Alex is really in the epicenter of this coronavirus crisis in the United States. Could you give us a sense of what it's like in New York City right now in terms of this crisis, Alex?
So yeah, there's a lot of media, a lot of news about what's going on here, and they describe a lot of terms of war, deployments, command centers. I think some, based on the institutions, depending on which institution you are in, some were better prepared and some were not. Personally, my institution had done pretty well. There was huge difference between different institutions. My institution closed down the hospital almost a month ago, stopped old visitors from coming in, stopped subspecialties like me, and retrained us to become COVID ICU, critical care personnel, COVID ICU ER personnel. So we've been deployed with our own team of our own TPAs, our own MAs and nurses to be deployed in needed areas of emergency rooms and ICUs to serve different functions. It was difficult. Last week, I'm personally trained in general surgery during trauma era in Brooklyn. So somebody like me is very familiar with a lot of sick people and people dying, but this was a little tough for me last week. We're starting to see a turnaround this year. I'm sure you guys all saw in the media of Governor Kwon mentioning this. I think that's true. Since about 24, 48 hours, we're starting to see, I think it kind of peaked out. It's getting better. We had a bed shortage, ventilator shortage for a very brief time, but sort of what you hear in the media, I think, is a little bit exaggeration. We had things under control. As a matter of fact, early this morning, what I was doing all day in the morning part was to assess people that can be transported to a USS Comfort and Jacob Javits Center and the Sam's Purse tent in Central Park, right next to my hospital. And those three groups were taking a lot of burdens off of our hospitals, especially my institution. And you guys all know about that little criticism about the boat not taking the COVID patient. They turn around, so they started taking a lot of COVID patients off of our hands too. So we're seeing a real turnaround. It's a very troubled time, but I think the worst might have just passed.
Are you seeing Chris had talked about the mortality rate of this disease. Are you seeing a lot of your patients away, or what is?
Yes. So, first speaking from my own experience, the first 2 weeks ago, we were deployed to ICU, COVID ICU. Last week, I spent most of the week in the emergency room. We were seeing a lot of mortalities, but a lot of patients that comes in who has a lot of comorbidities, patients from nursing homes who already had pulmonary issues to begin with, poor cardiac conditions, were the ones in trouble. We did see rather heavy burden of death. I know there was a very scary video that went out in one of our hospitals in Queens that had ran out of morgue space using refrigerators, cards where the dead bodies were going in. It's not untrue, but it wasn't as bad as was portrayed in the media. But definitely, there's a little bit of exaggeration of the media. But there were quite a bit of because the areas that were hit, the hospitals that were hit badly, the ones that didn't have enough resource to begin with. So that particular city-run hospital was in a bit of a trouble, which a lot of other hospitals jumped in. We sent our teams, and I think they were better even within a day or so.
How about you, Chris? You're in Texas, and
Yes.
I understand that while New York may be hitting an apex, perhaps other regions outside of this kind of East Coast area, you're a couple of weeks behind in terms of the apex. What are you seeing in Texas?
Yeah, I think that's a great point. And this country is so big in terms of geography. Different metropolitan cities across the United States are in various parts of this pandemic curve. And so we are certainly not seeing the number of cases, positive cases here in Texas as much as some of the hot zones of like New York, Louisiana, Washington State. And actually, they're all turning around a little bit right now on the West Coast. So as of right now, I concur with Alex that our ICUs are not really inundated as we speak. We do see a fair amount of COVID-19 patients in our ICUs. We have a fair amount of patients that are admitted to the hospital as a PUI, patient under investigation for COVID-19. But right now, our ICUs and our ventilators are not completely inundated and overwhelmed. But we do expect kind of a tsunami of patients that potentially will be coming through our doors. As we implement some forced social distancing measures, as most people call it, kind of the flattening the curve. Obviously, if you widen out the x-axis, if you will, that's going to delay the peak and also delay when the patients might be kind of coming in. And so, as of right now, our system is not really I'm not saying it, our CEOs are empty, but right now they're not quite inundated yet.
One of the things that I've read in the media, and obviously I'm not a doctor, but one of the things I've read is that there a lot of these patients that are coming in are suffering from ARDS, acute respiratory distress syndrome, but it's often associated with other cardiac issues and other kinds of issues that are not symptomatic or normal with upper respiratory distress. And so suggesting that this COVID-19 is a very unusual kind of virus. Could you comment on that, Chris or Alex, just from what you're seeing on the front lines?
Sure. You want me to go first, Alex?
Sure, go ahead.
Okay. I think some of the data that's coming out, when this first hit, actually, we were considering this more like kind of the SARS pandemic back in 2003. We thought that this was very much more upper respiratory type of symptoms and lower respiratory type of symptoms leading to more serious symptoms like ARDS. And some of the data that's coming out now, some of the patients from the front lines are experiencing all kinds of symptoms, not just respiratory type of symptoms. Some of them are coming with abdominal pains. Some of them they're not even coming with even upper respiratory, even lower respiratory symptoms. They're actually coming in with chest pressure and palpitations. Some are just coming in with some fevers and sore throat with some diarrhea. So I think the type of symptoms that these patients are presenting are very different. And so it kind of caught us off guard to a certain degree. And so even in our system that I oversee, we had to actually make a lot of quick pivots and adjustments of our triage and our treatment protocols, how we funnel patients in through the emergency room, depending on their symptomatology, changed greatly from 2 weeks ago. And also I've been reading some data regarding, I'm certainly not an intensivist, but I've been reading some data, and I would love to hear what Alex says about this, but I've been reading some data that this ARDS, what we call acute respiratory distress syndrome, is very different than the previous kind of generic ARDS symptoms that people are used to treating. I heard that the normal kind of ventilator support with proning and things like that actually is very, very helpful. But if you treat this much more like a normal ARDS, I think they will have a lot more difficult time. I also heard that people would be doing much better after a little bit of ventilator support, and the respiratory status is turning around, and it gives false sense of security and hope to the family members, and then all of a sudden they're hit with myocarditis, or there's a significant amount of hypercoagulable states, and people are presenting with pulmonary embolism, blood clots in the lungs. People who've had other pulmonary issues or cardiovascular issues obviously have because of the hypercoagulable state, they are having cardiovascular collapse, and they actually die of more myocardial infarction type of picture as opposed to the respiratory picture. And so that's kind of what we're seeing supposedly coming out from some of the hotspots, but I'd love to also hear from what Alex is experiencing as well.
Yes, I agree. I mean, this is a very different virus than, it is a similar family of virus, as we all know, but the way this behaves seems to be very different. And you're absolutely right. We sort of had to modify what we were doing initially, following the models after China and then Korea. But we do have a standardized form now where we're concerned about the lung, obviously, and oxygen saturation, but we're permitting a little bit more of a desaturation, because a lot of patients seem to tolerate somebody comes in with a level of saturation that we would really be concerned about, and yet they seem comfortable. But yet they could turn around within a minute or so. So we do even have a team of oxygen police. We have assigned residents and junior level residents going around constantly checking pulse saturations of these patients. We're definitely concerned about heart issues. Almost everybody gets EKG every few hours. And also the medication that's becoming standardized. Everybody hears about this hydroquinolones or chloroquinolones. These medications are sort of given and started along with the azithromycin. And we're constantly monitoring because they both can have effects on the hearts. And also hypercoagulable state is a big issue. Almost everybody is getting anticoagulation when they come in until they're ruled out. And that's the other thing, being ruled out of this is becoming much more fast now. We used to wait up until 2 weeks ago, we had to wait for more than a day, but now it's becoming a matter of hours. We can do this now in 2 hours, which can actually makes us able to make a lot of changes within that time. I think we're definitely doing much better. We had over 100 patients being discharged just within the last 24 hours from our system. We have a pretty large system, but that's pretty impressive, and I think it's a pretty good news. We're making changes. The people that the way the receptor works, it seems like the virus likes to bind to the same receptors that we use to work on our one of the high blood pressure medications, ACE inhibitors. So there's definitely a lot more binding of these virus to different part of the body, including heart, lung, and endothelial tissues. So that's why I think the characteristics of this disease is very different. I'm a colorectal surgeon by training, and I'm getting a lot of phone calls when I'm not in the ER or ICU. I still talk to my patients, my colorectal patients, and tremendous number of patients are calling in with the diarrheal symptoms. But when I talk to them, they don't actually have issues of intestine, but rather it's COVID.
So I wanted to talk a little bit about this idea of flattening the curve and the social distancing that's going on right now. The effort to flatten the curve is obviously to avoid the number of sick people running our current medical infrastructure in terms of beds and ventilators and so forth. But I'm wondering, as Chris mentioned, it's really to flatten the curve. You're actually extending out the time period of this, and many of our politicians are trying to get this thing over and done within the shortest time frame. But many of our public health experts are trying to extend it out so it doesn't we overtax our medical system. But I'm wondering, from your perspective, do you fear that perhaps we're going to go down to that flattening of the curve, and then maybe our policy folks say we need to save the economy? There's this balance going on right here, and they open up, and the resurgence of this, and so there's almost a tug of war between the public health community and the public policy and the economists on the other hand. But are you as medical experts, are you concerned about this? And is there a chance for resurgence, even though things may be going down, but all of a sudden we hit an inflection point and it goes right back up?
I think you're absolutely right. I actually live in New Jersey. I work in New York. We're, as you know, right next to each other. And I see a huge difference in these two states. People who live in New Jersey, New York, we go back and forth. It's the same people. We're not different in population, but what is different is the policy. In New Jersey side, we were forced to do social distancing. We were forced to work on this only 2 weeks different, but 2 weeks earlier, which made a huge impact in number of patients being surged into emergency rooms on New Jersey side. New York side was a little slow, but New York implemented the same restrictions, start to fine people and force people off the street. Right now, Broadway is completely empty for almost a week now. And this really contributed. I understand you're absolutely correct about balancing the economics of this with healthcare crisis being managed. But I think we're at a point that we must extend the length of the social distancing forced.
Chris, any comments?
Yeah, absolutely. I'm in agreement. I mean, we're doctors by training, and our value system is heavily geared towards health and safety of our patients and life and death issues. And so I completely agree in terms of what it is that we need to do in terms of flatten the curve to decrease the mortality as much as possible. At the same time, I am sympathetic to what the social policy makers are saying. I am sympathetic to the business people. I am a business owner myself, actually. And so I understand that, when they talk about certain aspects of the service industry just completely, utterly cratering, I'm sympathetic. But clearly, how do you put a value on our kind of our nuclear family structure, right? How do you put a value on saving kind of the service industry, the restaurant industry versus our grandparents and grandmothers passing away? And so I think you need to just kind of weigh that heavily, if you will. But at the same time, I am somewhat sympathetic to what the business leaders are saying. If I own a restaurant, if I own a bar, and I do know some of those people in my church that own service industries, I can't imagine kind of what they're going through. And so again, I'm sympathetic, but at the same time, how do you put a value on human life? How do you put a value on kind of saving our friends and family and our grandparents?
I want to shift gears a little bit here and talk about the Korean American Medical Association, and what both of you are regional presidents and are actively involved in helping the Korean American community through your role through this organization. Let's turn to you, Alex. And I know you've been through your organization have a wonderful website and many kind of resources for physicians and other community members to access. Could you talk about some of the efforts that your organization is doing right now?
Sure. So, Kama, you guys are all aware, but New York, New Jersey also has a lot of old local groups of physicians, Korean physicians, and we all kind of got together. And I'm involved with most of the organizations myself, including Kama New York chapter, which is called Kama Nim. We've formed a task force late February, and initially we started as a task force being concerned about possibility of this becoming a pandemic. We first gathered a lot of information from our Korean colleagues. We had connections to Korean physicians who were seeing firsthand experience. So we were trying to see, initially started with our own anxieties, try to share data. Is there anything we can do to prepare? And then we formed a group, including all the representative physicians from major organizations and major hospitals in New York and New Jersey, share data, try to warn the hospitals. Some hospitals listened to us, some didn't. Some state organizations listened, some didn't. And then we started working on strategies. We were teaching each other how to fight this. Some of them in the very beginning turned out to be not effective, but certain other medications, ones that I mentioned, which became a standard now, is something actually we started using more than 3 weeks ago because we noticed that this was working in Korea. Second thing was we started publishing this website, sharing the data to each other. We have our professional portion. Chris, you can actually join that part of that portion and share data. We have a lot of physician resource too. And then we also have
the website. Could you share us the URL?
Oh, sure. So it's http KDA-COVID-19. It's a Korean Doctors Against COVID-19, KDA COVID-19. We have a self-diagnosed tool there. So patient can actually log on and sort of go through, this is actually a copy of what the Koreans were doing. So they can actually self-diagnose themselves and tell them what to do. It goes through all the sequence of what they should do. And at the end, when they're really bad, we tell them to call the ambulance. But there are a lot of those steps that they need to go through. And it has a lot of general information. And for first 3 weeks or so, 2 weeks, we had to work on this because the data was changing, information was changing. It was a very interesting time at the beginning. Now it's somewhat settled. And also we have telemedicine options, volunteer physicians. We have a hotline, which is probably the busiest number right now, where it turns out that phone calls are coming in, not just from New York, New Jersey, but from sort of all over the country. What we didn't realize is that website when we designed doesn't know the state boundaries. So it's sort of spread all over, and we're getting phone calls from all over the country right now. We have a fair number of volunteers. We're training our medical students to answer these lines now too, because we are becoming a little bit more busier. We also have a donation line. We're getting a lot of donation through this, buying masks. A lot of the major institutions are okay with the N95 and KF94, but the individual practitioners are really lacking and exposed to this. And a lot of the private practitioners groups are having issues with the PPE. So we're starting to distribute some of these masks that comes in as donation, money that comes in. Next phase is testing. I know it's not standardized in the US. We're quite a bit far behind on what Koreans are doing. A lot of it because of a lot of bureaucratic issues of the FDA not allowing some of these things and testings that are being done in Korea, which we can't use yet. So we're kind of waiting on the testing yet, but in order to normalize our community and our society, we need to do better testing, more testing, so they can go back to their norm. So that's our next step. It's been quite an interesting hard ride, but we're starting to see sort of a lot of benefits, and we're getting a lot of feedbacks too, which is great.
It's wonderful.
Chris? Yeah, I'd like to add something. Yeah, I'd like to ask something about, since Alex mentioned about testing issue. I think that's a big issue for us here out in Texas here. I think the last number that I saw, positive number of cases in Texas, all of Texas, it's a big state. It's like 8,000 people. You know that number is not correct. Clearly, like for example, I think 2 weeks ago, they did some study about 25 surrounding counties around Houston. And I don't know the time frame in which this was done, about 900 people were tested positive for the coronavirus. But that same week, actually, there was about 900 some patients that were admitted to the hospital for possible COVID-19. So as we know, as we can back calculate, if about 15 to 20% of the population that gets hospitalized, you can't have everyone that's positive go into the hospital. So clearly we are under testing in Texas, and that's a really huge problem. Let me also give you an anecdotal example. One of my, we're in charge over 13 full service emergency rooms. One of the medical directors in our facility actually 2 weeks ago vacationed with her brother-in-law in Florida. She came back. She found out that her brother-in-law tested positive for COVID-19. So she was obviously concerned about herself because she needs to go and see patients and work in the ER. She's worried about cross-contamination and transmission, et cetera. So she called the public health department and said, I need to get tested. Now, granted, she is a board-certified ER doc who's a medical director of an ER. She could not get tested under that scenario, which in my mind, I cannot understand why that's so. So, I think, there's a serious problem. You cannot control anything that you cannot measure. Clearly, we cannot contain anything that we cannot measure. So at least in Texas, I'm sure it's like that everywhere. Testing is actually a huge problem for us. Now, luckily, we live in a capitalistic, decentralized society. Our ERs were able to contract with private laboratories like CPL, Quest Labs, and LabCorp, and we're able to find different avenues in the public health avenue to test our patients, testing our doctors. So we have kind of found the workaround around that. And around time for these private avenues have been fantastic. Quite frankly, self-quarantined from against my family for about a week because I was exposed to a positive patient who was a flight attendant based out of New Jersey, actually. I didn't don a full PPE. I had an N95 mask. And so, me and my family, we take care of a 78-year-old mother in our own household. And my wife is taking care of a newborn. She's got some comorbidities that I could not afford to even have minimal exposure. So I couldn't even hug my little babies for about a week. I tested myself. I went to work yesterday. I tested myself, and the results is back today. I got a call, a text from my nurse manager saying that, hey, Dr. Kwon, you are negative in COVID-19. So I was able to hug my little baby for the first time in about 7-8 days. And so it was an amazing feeling. But that just goes to show you that I think, testing is number one, a big problem. But if we can find ways around that, whether it's private sector, private avenues, I think it would be very, very helpful to help this.
Let me actually mention,
Yeah.
Let me just mention one or two things about the testing. So right now, as you know already, the PCR testing, it's twofold issue. Number one, it just like everything else that we do as physicians and healthcare workers, it depends on who's testing. This is the nasopharyngeal swab. It's a very difficult thing to do, especially if it's being done by someone who's afraid and scared and not fully protected themselves if they feel. So if they're not being really thorough with this probing and swiping, it will come out negative, number one. And also in my anecdotal experiences, one of my anesthesiologists tested negative twice until he was intubated, until we do a bronchial lavage. It wasn't coming out as positive. So we can't really trust that PCR, number one. Number two, availability is very different. Because of that, now it's getting better. Because of that, we were not testing everybody. Even if you do have symptoms, we were actually quarantined them in the very beginning without testing. We were testing the essential personnel, policemen, healthcare workers first when they develop symptoms so they can come back to work. Now, on the same note about testing, now we're actually doing Igg and Igm testing, which tells us patient had a recent acute positive status and now developing immunity to this. This is becoming very important, and we're doing more of this for the purpose of developing treatment for those that are really, really sick. Our institution is already working and treating patients with plasma from these patients who recently recovered. So there's a hope to this. I know we're probably going to talk about the vaccine a little later too, maybe, but without the development of vaccine, and I certainly don't think it's 18 months from now on, but even before then, we already had some armamentarium against this virus and its infection that it's causing.
Yeah, I totally concur. When my nurse swabbed me for this COVID-19 PCR test, it was an excruciating. I thought she was biopsying my frontal lobe, right? She went up so far. I didn't think there was a cavity that high into my face, but she went all up in there. And it's actually, I'm glad that you also mentioned the Igg IgM test. Actually, we actually implemented that 3 days ago. So I was able to actually test the serology test for Igg IgM, which was also negative, and the PCR test, which was also negative as well. So I'm glad that you mentioned different testing modalities as well. And I think as we kind of implement all of this, number one, I think better in terms of sensitivity and specificity will also come out. But also, one of the things that you mentioned also is not only just the availability, the swab, if you will, the testing kits, but when you send it away to whoever you send it to, whether it's the public health avenue or the private sector, there's also a delay in actually getting that thing turned around and getting the results back as well. So there's a twofold. There's a limitation, there's a bottleneck, rate limiting step in terms of availability of the swabs, but also the turnaround time, from what I hear in some of the hotspots, was it like 10 days for it to come around? I don't know if that's the case up in New York, but that's another frustration actually about the testing as well.
But is the situation better now, or is it
much better? But Chris is right. About 3 weeks ago, it was close to 10 days when you can get tested. But now in my institution, we do our internal testing. So it takes about 3 hours. And the Igg IgM testing that I mentioned, there are so many companies in Korea that makes them, and they're amazing. 30 minutes. Not even a drop of blood is needed for this. It's the same amount of blood that's needed to test your blood glucose. But they can't get through the FDA. It's all political issues preventing us getting access to these very cheap and effective testing. I'm hoping that US develops its own, or some of these can come in through the FDA. I think this will make the testing so much easier, and which is what our task force is actually working on right now as we speak.
Can we shift our conversation to vaccines? Alex, you mentioned about the importance of vaccines, and quite frankly, I mean, Dr. Fauci, who comes out on TV all the time, mentioned 18 months, and you mentioned that, Alex, 18 months. But if you think about it, 18 months is a long, long time. And does that mean that we continue to do these social distancing and other things until this vaccine comes out? Your thoughts on that? And then also, you had talked a little bit about drug repurposing too. If both of you could give me your perspective on, the likelihood, what is the vaccine issue, as well as, your support or your thoughts about the drug repurposing issue. So, Alex, how about we start with you?
Sure. So, and I respect Dr. Fauci a lot. And I don't know if Chris remember, he was our keynote speaker 2 years ago in our CAMA convention. Pretty amazing. But I think I have to disagree with him on this. The 18-month that he's projecting, I think, is using current FDA processing. If we're going to go through the current rules and regulations of FDA, yes, it'll take 18 months. But scientifically and medically, the actual vaccine can be produced much faster. So I think what will end up happening is we're going to have vaccine. I mean, University of Pittsburgh already has a successful vaccine, almost human trial level. But Korea and China already has some pretty decent models coming up. So they'll first start using them, and hopefully FDA can bend this rule. And as a matter of fact, speaking of regulations and rules, because Korea had experienced the MERS, and they really changed their regulation. They had rapid processing of testing kits and treatment options and medications and repurposing of medications for use of this purpose. I think that's what really made them be much more effective. And as a Korean physician, I think this makes us proud. And some of my non-Korean colleagues are always talking about this, and they're very impressed with Korean ingenuity, efficiency of Korean system.
Mhm.
Great.
Yeah, I can talk about the vaccine a little bit. And I think you mentioned something about repurposing of drugs. I've been reading about some studies, a very, very small study coming out of France regarding hydroxychloroquine plus azithromycin. This all came about. It was amazing because when I first read what South Korea was doing, again, I am so proud of our South Korean colleagues and what they were able to do. Let me take a step back. I've just never been so proud of our South Korean medical community. When they first published that genetic sequence of this virus, I mean, within one of the biotech companies in South Korea, within 3 weeks, using their artificial intelligence, he came up with a testing kit. Within about a week, like you said, Alex, to kind of getting rid of the bureaucracy of the certification process in South Korea, within about a week, they were able to approve this test. And that's why they were able to ramp up the initial testing and to be able to contain this epidemic. And I think speaks to a lot of that. And so when I actually saw, because South Korea was light years ahead of kind of treating this, containing this, they were putting patients on hydroxychloroquine and azithromycin early on. And so that got me started to looking at, well, how in the world could they think about this? And so I think there was a study back in 2013 and 2014, 2014 or so. It was kind of a fortuitous finding. It was a study looking at treating cancers, I believe. And they were using hydroxychloroquine to kind of use to help lysosomal apoptosis of some cancer cells. So what they fortuitously found in that study back in that day was that the hydroxychloroquine serves as a very potent ionophore for zinc. And what they found out was that zinc would come into the cytoplasm of the cell. They would interact with the ribosomal-dependent, RNA-dependent polymerase, and they would just stop the polymerase action there. So for those of us who are familiar with the molecular biology of kind of viruses, our viruses infect our mucosal cells. They get in the way of ACE2 receptors, like Alex had mentioned at the beginning of this webinar. They come in, they actually hijack our replication mechanism, like RNA-dependent polymerases, to replicate themselves, and that's how they basically increase the viral load of an infected host. But hydroxychloroquine is known to bring in the zinc into the cytoplasm, interact with the RNA-dependent RNA polymerase, and stop that replication process. And so we've known that from in vitro studies back in 2013, 2014. And so I think our South Korean counterparts were incredibly smart. They knew this, and they put them on hydroxychloroquine early on to basically kind of stop at least the replication process of this. Now, there was a French study that looked at this, and what they did was I think maybe 49. I read so many studies over the last month and a half. They kind of they get blurry, but I think there was like 49 patients in the study. Half them got hydroxychloroquine plus azithromycin, half of them didn't. What they did was they swabbed the nasopharyngeal swabs and quantified the viral load of COVID-19 on these patients pre and post hydroxychloroquine plus azithromycin. What they found was that there was a marked decrease in the viral load of these patients. Now, how does that translate to the actual clinical outcomes? It's difficult to tell. But clearly, it's shown in vitro studies that it actually stops viral replication. Clearly, it shows that it decreases viral load, at least in the nasopharyngeal swabs of these patients after they get hydroxychloroquine and azithromycin. So when there is no data, there's no definite kind of the silver bullet as of right now, what are you going to do with a patient in the ICU who are inches away from passing away potentially? What are you going to do? You're going to put them on hydroxychloroquine. You're going to put them on azithromycin. You're going to supplement with zinc. You're going to supplement with vitamin C. You're going to supplement even with melatonin. There's some studies that talk about melatonin and its effect on that. But we're going to see more data, and I would love, if this situation is not so tragic, it's actually a fascinating case study. socioeconomically, medically, in terms of research and development aspect of it. It's just a fascinating study. Now, another drug that I'm a little bit familiar with, remdesivir, used to be a drug that was officially, I think, developed for Ebola virus. And so they went through, Alex had mentioned kind of normal pathways of developing drugs. There's phase 1, phase 2, and phase 3. This remdesivir, it's an antiviral drug, originally developed for Ebola, I believe, had gone through phase 1 and phase 2. But then when they went to phase 3, it turns out that it was not effective against the Ebola virus. And so we had this same drug that we can give, and I think there's randomized clinical trials going on remdesivir regarding the efficacy of that. I haven't seen any studies coming out regarding that as well, but that's another potential repurposing of drugs that were previously developed.
So the bottom line is we have drugs to help people who are already sick and maybe control their sickness, but we still, the vaccine, it will be ultimately the silver bullet that will help give people the protection to protect themselves from this disease. And so until then, we're going to be faced with this societal issue and trying to protect ourselves through social distancing and other things. So is that essentially the bottom line, I guess, from this conversation? Okay. Well, both of you have been extremely generous with your time, and I really appreciate it. But I wanted to conclude with a couple of last questions. And both of you obviously are on the front lines of this COVID-19 war, as we've described it. If there are people in our audience, many of our audience are business leaders, and there are also people in a variety of different sectors, as leaders in those areas. If they want to help our public health community, our medical health communities, what can they do? Obviously there are things that we can do as individuals, and we know about wash your hands, social distancing, but are there other things that we can do? And I think, Alex, you had mentioned a few things we could do through the website, but are there other things that we can do as a community to help our medical community? So how about if we start with you, Alex?
Sure. So through the same hotline that I've been answering during my downtime, I would go on this hotline and talking to patients who are calling in, but actually quite a few phone calls are coming in from community leaders, restaurant owners. There are a lot of people who are willing to help, and they do have a lot of roles that they can play. Hospitals in New York City are basically inundated right now with free food, free things for healthcare workers. You know about 7 o'clock clapping that goes on, siren that goes on cheering us. It's pretty amazing. I think us healthcare workers are okay. And I'm more concerned about elderlies, those of us who doesn't have a lot of families, nursing homes. So nowadays, I'm telling these people who are calling the hotline not to be concerned about their own health or questions, but they want to help. There's so many people who wants to help. And I'm telling them to look at our neighbors. Maybe somebody needs some food. If you haven't seen an old lady or old gentleman who hasn't been outside, just make sure they have food. You can do some food shopping, drop it their front door and just walk away, things like that. So I would just tell them at this point, look to the neighbors. I mean, they are doing a great job donating masks and money to us too, but I would say this is going to end soon. At least this until it sort of hits us again. For now, it's okay. Look toward our neighbors.
Yeah, I can't emphasize that enough. I was thinking hard about, what we can do. And one of the things that I would like to bring up, actually, the Korean American community across the United States is really not, as you can imagine, not really a homogeneous demographic, right? And so if you can imagine, the heart of New York City is going to be full of highly educated, professional, probably close to second generation, upwardly mobile professionals who can speak English very well. But if I can just look at the microcosm of the Korean American community in Houston, it's a little different. I would venture to say, if you look back maybe 20 years of what New York was 20 years ago, in terms of the demographics, maybe that's what you would find in Houston, meaning there's a lot more kind of the Korean speaking, first generation, older demographics. I mean, you know, don't get me wrong, there's a fair amount of professionals involved in the oil and gas industry in Houston. But I'm less concerned about these highly educated, upper level mobile professionals. They're gonna be informed, they're gonna find data, and they're gonna protect themselves. And one of the things that Alex brought up, I really, really appreciate, is because I would venture to say the younger generation, the more informed decision maker of our Korean American community needs to look after the previous generation, our mothers and fathers, our grandparents. We need to make sure that clearly, you know, the social safety nets of our government is not enough. Churches can only do so much. So there are going to be patients or even people that are going through this draconian forced social distancing measures. They're going to fall through the cracks. They're not going to have the food that they would need. They might not even understand the gravity of the situation, why it is that society is making them stay home. I had a friend of mine who lives with his parents as well, but they keep on having to fight them sneaking out and going to Costco, right? So that's a perfect anecdotal example of how the younger generation, more informed generation, can really, really help the older generation to understand the reasons why we're forced to social distance, etc. Like Alex had mentioned, we need to really think outside of ourselves to be the social safety net of our society and our communities. Really look after our neighbors who might not have the means that we might necessarily have. Look after our parents, look after our uncles and aunts. I think that is the greatest thing that we can do to fill in the gaps of the social safety nets that I think will be woefully deficient as we go through this.
Well, thank you very much for that. I want to give each of you a final word to share with our community. Alex, I know you had a message you'd like to give in Korean. So over to you, Alex.
Okay, thank you. So I think I'm 1.5 generation. I think more of a 1.5 generation than Chris maybe. So I'm still more comfortable with Korean. 한국말로 한국 옛말에 한국 사람들이 하는 말 중에 좋아하시는 어르신들이 좋아하시는 말 중에 하나가 상부상조라는 말이 있는데요. 상부상조. 서로 돕는다는. 지금 이런 때일수록 우리 한국 사람들 서로 하는 옛말이 많이 어플라이하는 것 같고 또 주위에 있는 제 컬리그 한인 의사들 그리고 코리안 커뮤니티를 봤을 때 상부상조하는 마음으로 돕는 모습들을 많이 볼 수 있어서 정말 가슴이 포근하고 좋습니다.
Thank you.
That's it.
Chris, final word?
Yeah, fantastic. I think two things to say. I think when even after we pass this peak surge, if you will, I believe this will be a marathon. So I think we need to adjust our expectation. This virus most likely is going to be endemic. By that I mean, 2 years from now, we're going to swab our patients in the ER for influenza A and B, and we'll probably swab our patients for coronavirus. And so as far as our businesses are concerned, our service industry sectors are concerned, and in terms of the various social distancing measures, it's gonna feel too long. But I think it's gonna be necessary to flatten the curve, if you will. So number one, I would like to say that it's gonna be a marathon, but at the same time, when we go through trials and tribulations like this is when I think the best aspects of us will come together. And these trials and tribulations not only kind of develop our character, but I think it would show our character. So if our Korean American community can come together with a singular purpose to help our neighbors and our family members to get through this, I think number one, we'll do much better. So number two, I've experienced this personally myself. I think it made me, as we go through this hardship, as we go through this pandemic, as I go through all kinds of difficulties, whether it's business, whether it's clinical, whether it's a social, economic, believe me, we're all going through the same thing. But as I go through this hardship, what made me really realize is that through this, I'm taking inventory of what is really important in life, right? Faith, the fact that I can actually now hug my baby, and which I took it for granted. Hugging my little baby after about a week almost brought tears to my eyes. And so I think what's going to happen as we go through this hardship is that we're going to take inventory of what is really important to us, and everything else that's not essential in our lives, if you will. What we thought was so important, in the end, will end up being not so important. I think we'll understand through this that family is important, faith is important, freedom to go about where we want to go about. We're going to cherish freedom more than we've ever done before. And obviously, life and death and healthcare issues that we took for granted are going to be very important to us. So I would like to say that, hey, take inventory of our lives, really focus on what you think is really, really important. And I think that will come through this pandemic.
Well, thank you, gentlemen. Thank you, Dr. Kim and Dr. Kwon. Thank you for your service, as well as your time over this last hour to share with us your insights, your wisdom, as well as your encouragement. So thank you very much to both of you. We appreciate it very much.
Thank you.
Thank you. Thank you for having us.
So if any of this information from this webinar, or if you're interested in seeing past webinars and being signed up for future programs, we encourage you to visit our website, councilka.org. That's councilka.org. With that, we hope you enjoyed today's webinar, and we hope you find it very informative and help you navigate the current crisis with this COVID-19 pandemic. Thank you very much.